Welcome to the Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Sila Bal, and my guest today is one of my very best friends in ophthalmology, Dr. Brian Shafer. Dr. Shafer is a cataract, cornea, glaucoma, and refractive surgeon and the founder and practice owner of Shafer Vision Institute. Dr. Shafer, Brian, thank you so much for joining me today.
Sila, this is about to be so much fun.
I cannot think of anyone who could take this topic and make it fun, but if anyone could, it would be you.
Well, we're going to do our very best.
We are going to do our very best because today's episode is actually a special episode that I have been waiting to record until we found the right person to tackle this extremely dense topic. And that topic is glaucoma studies. We will not be presenting a case today, but instead, we're going to review some of the high-yield glaucoma studies. These studies are extremely important in guiding clinical practice for our patients, but for our young listeners out there, they are also heavily tested and require a deep understanding to be able to pass those OCAP and board questions. I know that Brian and I were just talking about how we were tested on this heavily, and a lot of the information is high yield. So this is going to be such a great episode. Starting out, we went back and forth about this before starting this episode. Which study do we start with? What makes the most sense? And we decided that the best place to start would be with glaucoma itself. So let's start with understanding the benefits of early treatment of IOP in glaucoma patients, and specifically the study, the Early Manifest Glaucoma Treatment Trial. Dr. Shafer, what can you tell us about this trial?
Sila, before we jump into the trials themselves in particular, I want to just take a step back and remind all the listeners that these pivotal glaucoma trials all took place in the 20th century, prior to the widespread adoption of prostaglandin analogs, SLT, angle-based surgery, and importantly, OCT as a measure of following glaucomatous progression. Therefore, the results of these studies must be contextualized to reminding ourselves that the treatment options and the diagnostic options were more limited. IOP, visual fields, and stereoscopic disc photos were the main ways in which glaucoma was followed at the time of these trials. Don't take this as me saying that these studies are no longer relevant, and in fact, it's the contrary. They've really guided the way in which we understand and treat glaucoma for the past almost 30 years. And now we get to take the opportunity to take the treatments and the diagnostics that we have now to push us forward and do what's right by our patients. Leading us off, I want to make sure that as we go through these trials, all of our listeners have more of the story than I think you and I maybe had when we were starting to learn the glaucoma trials. It was really hard for us to keep all of these names in our heads as we went through them. You've got the EMGT, you've got the SIGITs, you've got the SINGITs, you've got the OHTT. They're all just letters, and it's just like a letter soup to me. But I think if we really think about what these trials were trying to show us at the time points at which they were done, it's going to be easier for us and easier for our listeners to have the context. Starting with the Early Manifest Glaucoma Treatment Trial, what we were really looking at here was, when we have a patient who has glaucoma, should we treat them? It sounds so obvious to us now, right? Of course, glaucoma is a disease of high pressure in the eye that the only treatment we have is to lower the pressure. But at the time of this study, we didn't know if that was actually what we're supposed to do. So the goals of the Early Manifest Glaucoma trial were twofold. The first was to compare the effect of IOP lowering treatment versus observation on the progression of early newly detected and untreated glaucoma, as well as to assess the magnitude of any treatment effect. So again, we first wanted to see, is it even worth doing? And the second thing we wanted to see is, if it is worth doing, how much of an effect do we have? So what did we actually do here? These are brand new glaucoma patients. They all had elevated IOPs over 21 with field loss associated with enlarged optic nerve cupping. Remember, we didn't have OCTs at the time. These patients were randomized to either be observed or to have treatment with betaxolol, which is a selective beta blocker that we largely don't use anymore, and ALT, so both of them. and they were watched until there were signs of progression. This was a multi-center randomized clinical trial, and they had patients ages 50 to 80 years old. And effectively, what we were trying to take away from this was looking at who progresses. And what we learned is that in the observation arm, 62% progressed without treatment, 45% progressed with treatment. That means that there's only a 17% relative risk reduction in treatment. However, those numbers can be deceiving because remember, our treatment options were limited, and this was purely observational. In utilizing this beta blocker in addition to ALT, this means that there was a large variety of responses to these patients. Univariate analysis risk factors that were shown were patients who received no treatment, had higher IOPs, who were older, had pseudoexfoliation, visual field losses, and bilateral disease. They then went and did a multivariate analysis to show who actually had less of a risk of progressing based on their response to treatment. Multivariate analysis showed those same risk factors, but interestingly, frequent disc hemorrhages was also seen as another risk factor. We now think about that. Our patients who come in with a disc hemorrhage, we think, okay, this means that their glaucoma is not stable. This is really one of the first places that we understood that. Importantly, and a key takeaway here, is that for every millimeter of mercury of reduction, there was a 10% relative risk reduction in progression of glaucoma. I'm going to repeat that. Every millimeter of mercury reduction led to a 10% relative risk reduction in progression of glaucoma. Ultimately, what this is showing us, the early manifest glaucoma trial, it's showing us that patients who have glaucoma, who are treated for glaucoma, have less of a risk of progression of their glaucoma. Key takeaway, treat glaucoma, because if you don't, they have a risk of progressing. One thing I'll mention within this study that will differ from the next study we talk about is that IOP fluctuations were not seen as a risk factor for progression here. That is the early manifest glaucoma trial.
That is just the most perfect summary that I could ever think of. And I love that you emphasize the 1 millimeter mercury reduces IOP by 10%, because that's something that you will get asked your very first day on your glaucoma service and something that you think about often when you are seeing these patients. Okay, so moving on to our alphabet soup of letters, we are going to look at the collaborative normal tension glaucoma study and the collaborative initial glaucoma treatment study. It's a mouthful. It's a mouthful for me to even say it here talking to you. But the reason we put these two together is that they sound similar, and they're looking at not quite the same disease pathology, but they're looking at similar things. So, Dr. Shafer, can you tell us a little bit, but first about the collaborative normal tension glaucoma study and then the collaborative initial glaucoma treatment study?
The collaborative normal tension glaucoma study was piggybacking off of the early manifest glaucoma trial. Remember, the early manifest glaucoma trial was looking at patients who have elevated IOPs and optic nerve damage, aka glaucoma, and should we treat them or not? Well, up until this point, we weren't certain, is normal tension glaucoma really the same disease state? Is it an IOP dependent disease? Or is it something completely different? Ultimately, the goal here was to look at patients with what was considered to be normal tension glaucoma based on normal IOPs less than 21 on average and 24 at its absolute max. Keep that in mind because now we refer to 21 as our max. But they, in this study, they could never have had a measurement above 24, but their average had to be about 21. And the goal here was to see if you treat these patients who appear to have glaucoma but normal pressures, if you treat them by lowering their IOP, do they do better and have less future visual field loss? Ultimately, the answer was yes. There was less visual field loss in patients with normal tension glaucoma who ultimately had treatment compared to those who had observation. In summary, IOP plays a role in normal tension glaucoma. Again, this is one of those studies that we think about normal tension glaucoma as we go through our clinics now, and we know to our core that IOP is the only modifiable risk factor. But we didn't always know that. And remember, in science, we only know things when we conduct a randomized clinical trial. And this was the randomized clinical trial that really proved to us that IOP plays a role in normal tension glaucoma and that lowering IOP is important to prevent field loss in the future.
You're so correct. So that normal tension glaucoma trial and any trial really, I always joke with my fellow doctor friends is unless we see the evidence for anything, right? We will not believe it. So whatever it is, we want evidence-based medicine, but we also want evidence-based life. We want everything in our life to be evidence-based. So just shifting a little bit from the normal tension glaucoma study to the collaborative initial glaucoma treatment study. So now we're going from normal tension back to our glaucoma patients with elevated IOP, since we know that IOP plays a role. How is that different?
SIGITS is a really important trial. We now know from the early manifest glaucoma trial and the collaborative normal tension glaucoma trial that we have to lower IOP in order to prevent future visual field loss. Again, in other words, IOP is the only modifiable risk factor in glaucoma. The question here is what should we do to lower a patient's IOP when they are diagnosed with glaucoma? There are multiple options for how we do this in clinical practice. We can use medicines, lasers, and surgery. And over the lifetime of a glaucoma patient, we tend to do all of those things. And as we move through time, we have a better sense of how we can position these things. But it was the collaborative initial glaucoma treatment study, SIGITS, that really helped us first answer the question, should we start with medicine or should we start with surgery? So these were all patients who were diagnosed with glaucoma, open angle, had to be either primary pigmentary or pseudo X. And these patients were randomized to either undergo medical treatment or surgical treatment. Of note, within this study, they had very aggressive IOP reduction goals. In both the medical group and the surgical group, they were instructed to have their IOPs lowered by whichever method they were randomized to as much as they possibly could, up to 30% or more, if they could. In both arms, we saw that lowering IOP aggressively led to low rates of progression. Now, in the medical arm, we really had our beta blockers. And in our surgery arm, we really just had trabeculectomy. And what this showed us is that whether you beta block someone or you trab somebody, if you can get their IOP low enough, they likely won't go on to progress as much. But the nuances of this study really were in the more moderate to severe patients. Patients with more moderate to severe glaucoma fared slightly better if they had surgery first. But in reality, these results were mostly non significant. And either way, whether you did it with medications or with surgery, patients didn't progress as much. One thing of note in this study, compared to the early manifest glaucoma trial, where IOP fluctuations did not play a role in progression, in SIGITS, patients who were in the medical treatment arm, IOP fluctuations were a risk factor for progression, whereas in the surgical arm, patients with IOP fluctuations were not a risk factor. This was unique to this study. One other unique factor to this study is that it included quality of life. This was our first major glaucoma trial that included quality of life. And what it showed is that in the end, it really balanced out between the two. But in the early phases, patients who underwent surgery of course, had to undergo post-operative periods, and that came out in the quality of life studies a little, but in the end, they completely balanced out. In summary, Medication versus surgery is pretty much the same in terms of progression as long as you have an aggressive IOP target.
I love that they looked at quality of life measures, and I do wonder if we should be including that in essentially all of our trials at this point, because what are we doing if not treating the patient? Are we just treating a disease, or are we treating the patient and how we treat the patients? So, surgery sometimes feels a little extreme, right? Going directly to surgery, even if it has equivalent outcomes by SIGITs. What about lasers, right? What about the effectiveness of lasers? And that brings us nicely into our next study, which is the Advanced Glaucoma Intervention Study, or AGIS. Brian, can you tell us a little bit about that?
Sure. And I want to remind our listeners that when this study came out, when all of these studies came out, SLT was not a thing. And just a quick plug for the world of interventional glaucoma, we now have more trials, such as the LIGHT trial, that shows us that SLT is both a cost effective and efficacious first line therapy for primary open angle glaucoma and ocular hypertension. At the time of these trials, we only had ALT, argon laser trabeculoplasty. It's a different mechanism of action, and it is no longer mainstay of treatment. But at the time, AGIS, or the Advanced Glaucoma Intervention Study, was looking at, if you do start with intervention, is it best to start with laser, or is it best to start with trabeculectomy? What this study did is it compared the clinical outcomes of two treatment sequences. In one arm, you had ALT first, and if that failed, you went on to a trab, and if that failed, you went on to another trab. Compared to trab first, then ALT if that failed, and then trab again. This was actually a very big study. There were 789 eyes of 591 patients with medically uncontrolled open angle glaucoma. What this study showed us, beyond what the treatment algorithm itself was better, it showed us that we need to take into account patient differences. And in this study, the main patient difference is race. Ultimately, white or Caucasian individuals do better with the TAT, trabeculectomy, ALT trabeculectomy pathway, and Black people do better with the laser first, the ATT, ALT, trab sequence. This is so critical because nowadays, when we think about who to intervene on and how to intervene on them, patient demographics truly play a role in this. And this was our first study looking at the results of these surgeries and how race is impacted in that. What we can now sort of reason out on here is that more deeply pigmented individuals tend to be more robust scarers. And at these times, they didn't necessarily have mitomycin at the time of trabeculectomy. So a trabeculectomy on a deeply pigmented individual is going to scar fairly quickly compared to on a more lightly pigmented person. Therefore, it makes sense that laser would work better rather than trab in a more deeply pigmented person.
It's always so incredible to me to think about patient demographics and how that impacts not only the evidence that we currently have, but also how we treat patients, sometimes based on things that are a really homogenous population. So, whether that's all white patients or all white male patients. I don't know if you've seen recently, but there's been these viral posts about all of the sleep studies being on white men and how sleep requirements may be different according to gender or different racial groups, and how we've based all of these recommendations off of a very specific demographic. So it's fascinating, but let's shift our gears one more time and think about our surgical options. So we have these two excellent surgical options. We have tubes, we have trabs. Which one is better? And that leads us right into the tube versus trab study.
The TVT study, or tube versus trab study, was really the study that was looking at which option is better to start with for our patients. At the time, these were really our only two surgical options. Now, of course, we have many more options with minimally invasive glaucoma surgeries, other types of subconjunctival surgery. But for a while, all we had was tubes and trabs. Keep in mind, this study was looking at specifically valveless tubes. This is not valved tubes, this is valveless tubes versus trabeculectomy. The goal was to see who got the pressure down more and which was safer. And in the end, they were kind of the same. At 3 months, both procedures led to the same sustained pressure reduction, the goal being the low teens, and that was sustained throughout the 5 year duration of the study. There was a higher long term success rate in the tube group versus the trab group. And importantly, the tube shunts had a lower rate of early postoperative complications and reoperation for glaucoma, which makes sense to us. With trabeculectomy, you sometimes need to needle, you sometimes need to revise a bleb. But in the end, both tubes and trabs met very similar endpoints and were virtually non inferior. However, in the first 3 months, trabeculectomy plus mitomycin C did lead to slightly lower IOPs and less use of adjunctive medical therapy in the first 2 years. So, what this really shows us is that you're not wrong to be a trab only person or a tube only person if those are the things in your toolkit. But there are a couple of nuances, specifically that trabs have lower IOP early on and that tubes require less repeat surgery. This really has helped us dictate what types of patients we should be doing these different procedures on, going back to AGIS, the Advanced Glaucoma Intervention Study, remembering that race is a real factor here, and darkly pigmented people do worse with bleb-based surgery. This has led to a lot of nuance in the way in which we treat our patients, because we now know, because of TVT, we can achieve similar rates of IOP reduction, keeping sustained IOP in the low teens, and they're both going to do a great job. You can dictate which patient you do it on based on the nuances of that patient.
I think we've had so much important information here about glaucoma treatment. And I know the listeners are probably thinking, okay, so Dr. Shafer, what do you do? What are those nuances? How do you choose tube versus trab? Any recommendations? I know it's a difficult question because it really depends on the patient in front of you, but how do you approach these patients? How do you kind of think through a patient?
I really look at the demographics of that patient. Let's assume we're only talking about primary open angle glaucoma that's uncontrolled with their current regimen. Typically, I do angle based surgery in these patients. And if that doesn't work, that's when we're talking about doing subconjunctival surgery. And for patients who are older, more lightly pigmented, bleb based surgery is the way I go. For patients who are a little bit younger or more deeply pigmented, tube shunt is the way that I go. And of course, these are conversations with the patients, and there is nuance there, but generally, that's how I think about it.
Thank you. I think that's super helpful for the audience. So, we're at our final topic in this very, very, very dense topic, and that is ocular hypertension. So, we're no longer in the realm of this patient definitely has glaucomatous optic neuropathy, and we're more in the realm of the pressure's high. What do we do? So, Dr. Schaefer, can you first tell us what is ocular hypertension and what are the studies that tell us how to manage these patients?
We know that glaucoma is a disease of high pressure in the eye that causes damage to the optic nerve, leading to reproducible visual field deficits based on the loss of nerve fiber layer and ganglion cells. If you take away the second half of what I said there, you have ocular hypertension. You have high pressure in the eye, but none of the other stuff. And that's critical, because if you have high pressure in the eye, but none of the other stuff, you don't have glaucoma. It's not mild glaucoma, it's not glaucoma. So, ocular hypertension, which is by definition IOP elevated above an arbitrary cutoff value, typically 21 millimeters of mercury, with the absence of optic nerve damage. and no visual field abnormalities. Now, we're going to get into that arbitrary cutoff value of 21 millimeters of mercury in a moment based on this study, the ocular hypertension treatment trial, the OATS study. And the reason that I say we're going to get into that is because one of the main results that we see from this is that central corneal thickness is a major risk factor for glaucoma. And for all of our listeners here, we know that IOP in isolation means nothing because an IOP of 21 in a patient with a pachymetry of 650 is very different than an IOP of 21 in a patient with a pachymetry of 460. They're radically different IOPs. You've got to adjust based on that central corneal thickness. And how do we know we have to do that? Because of the OATS trial. So the OATS trial was looking at, do we just observe patients with elevated IOPs or do we treat patients with elevated IOPs? And ultimately, what this looked at was which of those patients that weren't treated had higher risk factors for progression. Ultimately, what this showed is that patients who received treatment had a lower risk of progressing to true glaucoma. However, what's important to note is the specific patients in which the multivariate analysis showed us had a higher risk of progression with ocular hypertension. This is what I want you to remember. The results of the ocular hypertension treatment study suggest that older age, higher IOP, thinner corneas, larger baseline cup to disc ratio, and higher pattern standard deviation on the visual field are important risk factors for the development of glaucoma. In this study, treatment with topical anti-glaucoma medications decreased IOP by about 20% and reduced the incidence of glaucoma by 60% compared to observation. Ultimately, this has really helped us figure out who do we actually need to treat or not. And it's those patients I just mentioned, the older patients with higher IOPs, thinner corneas, bigger cup to discs. And now, based off of this trial, we actually have the OATS calculator. And I do this with all of my ocular hypertension patients. When they come in, they've got high IOP, but no other signs of glaucomatous damage. I pull up the OATS calculator. And when you literally just Google OATS calculator, there's a couple of different ones. And you type in what's the patient's age, what's their cup to disc ratio, what's their IOP, their central corneal thickness, and what is their pattern standard deviation. And it tells you what is this patient's risk of progression to have real glaucoma in 5 years. It's actually fantastic because this study has shown us who do we need to treat and who can we just observe. This is a really important trial that really changed management in my practice and practices all around the country and world.
That's such a helpful little tip too, to use the oats calculator. I don't regularly use it. I also don't regularly see glaucoma patients, but I think that I will probably have more of a comprehensive practice. So I am definitely going to reference that. Dr. Shafer, this episode is just so full of great information. And just like I predicted in the beginning of the episode, you did such a fantastic job at summarizing what would be a very dense topic. And I have a feeling that the audience is going to want to listen to this episode a few times just to really drill in those topics. So, thank you so much for walking us through that. And before I end the episode, I ask all of my guests, and you are not exempt from this, if you could have dinner with one person from any time or place in the history of humanity, who would it be? I am so excited to hear your answer.
The most important person in my life was my grandmom, my me mom on my mom's side. And if I could have dinner with a single person, it would be her mom, both so that I could understand how she created such a perfect human, but also just to get a even fuller understanding of who my me mom was from childhood. And also to tell me mom's mom how proud she should be of having raised the most amazing person I've ever known.
That's such a beautiful answer. And I'm sure, is me mom still alive?
Unfortunately, not. She would be about 103 if she were. So she lived a great life.
That's my personal goal, but I'm sure wherever she is in the ether in the universe, she is hearing this and smiling ear to ear. Dr. Shafer, thank you for joining us on this episode of the Pupil Pod.
Thank you so much.
And thank you to those tuning in. See you next time on the Pupil Pod.